So delighted to welcome Renelle Myers. Renelle is Clinical Associate Professor of Medicine at the University of British Columbia and a clinical scientist at the BC Cancer Research Institute. She's an interventional respirologist with a cross appointment in thoracic surgery and director of bronchoscopy at Vancouver General Hospital. The director of the Lung Breath Lab, the first clinical breath lab in Canada, and research interests include early diagnosis. So Renelle's talk is breath biomarkers for the early detection of lung cancer. Thank you very much. Over to you.
So good morning from Vancouver, Canada. It's around 8:15. So I'm going to try to use my early morning energy to keep you entertained for the very last talk of the day as you guys are winding down. Thank you for the introduction. It is a little intimidating following Dr. Risby, but it was a nice introduction, and I will comment on a lot of the smoking comments that he had referred to. I'm an interventional respirologist and spend a lot of my time doing lung biopsies, diagnosing cancer and staging, and then sharing that devastating diagnosis with patients and their families. So my research interest into the early detection of lung cancer really stems from that. And today, I hope to give you a good review of the literature on lung cancer screening and introduce the current challenges that still remain in lung cancer and how we think we can introduce breath biomarkers into the pathway at several points to benefit patients. These are Canadian cancer statistics. You can see that cancer is the #1 killer of Canadians. And of the cancer killers, the #1 cancer mortality is lung cancer. And it kills more men and women than prostate, breast, and colorectal put together. Globally, the worldwide burden of lung cancer will continue to increase, and it's projected to rise, especially in the coming years in Asian countries, not only because of the population size, but because we're seeing a very steady incidence in males, and we're seeing an upward trend in females. So this is data from Taiwan, just to emphasize this dramatic increase in females with adenocarcinoma. The majority of them are never smokers. 93% are never smokers, yet it's the #1 cause of cancer death is in female patients, with 70% having adenocarcinoma. So you can see that the burden of this disease is enormous. The reason for that is the net survival. Despite a lot of advances in therapies such as immunotherapy, targeted therapy, our 5-year net survival still remains very low and less than 20% for this disease. The good news is we know that when we can find it and treat it early, we have a significantly improved outcome for patients. So this is a Kaplan-Meier curve looking at the different stages of lung cancer. 1A1 is very early stage. This is a 10 millimeter nodule. A 1A2 is 10 to 20 millimeters, and a 1A3 is 20 to 30 millimeters. So these are very small nodules, but you can see the dramatic improvement in outcome if you capture patients at this stage versus a later stage. We know we can do this with lung cancer screening, and this is relatively old news. In 2011, the first large randomized control trial looking at lung cancer screening using low-dose CT scanning versus chest X-ray was published in the New England in 2011. They demonstrated that eligible participants that were deemed high risk for lung cancer included age of 55 to 74 years. We know that from SEER database data that as you age, you are at increased risk of lung cancer. They were heavy smokers. They had at least 30 pack years. So this is looking at participants that have smoked a package a day for 30 years. They had quit if they had quit, it had only been 15 years previous. So this was the demographic of patients that were deemed high risk and enrolled in the trial. And low-dose CT scanning showed a relative reduction in mortality of 20%, which was enormous and arguably the largest reduction that we've ever seen in lung cancer mortality. So this was a really big deal. And why hasn't lung cancer screening rolled out globally around the world yet? This is 9 years ago. Well, because there was a lot of doubt in terms of, are we overdiagnosing these nodules? There was a large false positive rate, and these nodules needed to be followed. We find a lot of lung nodules, but the vast majority are actually benign. And so the what we know that lung cancer screening saves lives because we get this very early stage shift. So this is Canadian data in the green from Cancer Care Ontario. This is our largest province, and it's its cancer organization, showing that along the x-axis is the stage of lung cancer. And you can see that the majority of patients present in stage 3 or stage 4 without screening. When we start to do lung cancer screening with low-dose CT scan, as was done in the Pan-Canadian lung cancer screening trial that looked at 8 centers across Canada using low-dose screening, we get this really beautiful stage shift. So now that you see the vast majority of participants are actually diagnosed at stage 1, 77% were detected at stage 1. This is when we know we can surgically cure and really change the outcome and landscape of lung cancer. This has been reproduced in many lung cancer screening trials. For example, the UKLS screening trial demonstrated 62% were diagnosed at this early stage. So it took until 2020, January of 2020, and the long-awaited Nelson lung cancer screening trial, which is a large Dutch-Belgian trial that looked at over 13,000 largely men enrolled and recruited to lung cancer screening through population-based registries. They were actually looked at screening with low-dose CT scan versus no screening or standard of care. Interesting, they looked at different screening intervals, and they actually used volume or volume doubling time of nodules. And these patients were followed for up to 10 years. They deemed a little bit younger patients to be high risk. So they dropped the age a bit, and this is important going forward. And they were also lighter smokers, so less than 10 cigarettes for 30 years. And this is a little bit younger and a little bit lighter smoking history than in the National Lung Screening Trial. But we still see this mortality reduction in the screening group versus the control group. And this study confirmed a 24% mortality reduction in males, which reiterates what we found in the National Lung Screening Trial. And interestingly, the study wasn't powered to look at females because the majority of patients were males, but there was a 33% mortality reduction in females. And this trend with mortality reduction, more mortality benefit in females with lung cancer screening has been seen in several other studies and needs a closer look to it because it's a very interesting. With this new data of a younger, lesser smoking population, it's made the US Preventative Task Force, which in 2013 started guidelines for lung cancer screening in the United States. In the United States, there are over 650 lung cancer screening areas and programs across the country. They use 55 to 80 years with a 30-pack-year smoking history and have quit within 15 years. But after the Nelson publication, the new proposal for 2020 is to reduce that age and reduce the smoking history. And that's because we know that we're missing a large portion of patients who develop lung cancer that aren't eligible for screening. There is debate on how do you pick this ideal population. You want to screen that really high risk population that are going to benefit the most from lung cancer screening. And currently there are 2 ways, validated ways. One is, as I showed you in the 2 studies, the Nelson and the National Lung Screening Trial, is to use age and smoking status. But we know that risk prediction models have generally outperformed these. The risk prediction model called the PLCO M2012, which was created in Canada by Martin Tamamagi, incorporates also a BMI, a level of education which represents socioeconomic status, a history of COPD, and a personal history of cancer, as well as a family history of cancer, incorporated into a risk calculator that can be web-based. So you punch in these, including their smoking status and age, which gives you a 6-year risk of lung cancer. The jury's still out into what is the best way to select this population. And so this is where the International Lung Screening Trial comes into play. This is a large study involving 5 different countries around the world who are prospectively enrolling high-risk patients based either on the US Preventative Services Task Force-like criteria, which is age and smoking history, or a risk factor model looking at using the PLCO. So of all the patients that have been enrolled, and these are interim results so far of around 5,000 patients, we can see that risk modeling outperforms age and pack years in selecting those high-risk patients. You can set your risk prediction model at 1.51% risk over 6 years. You can increase it to 1.7% or increase it to 2%. You will decrease your sensitivity somewhat, but overall you will remain outperforming age and pack years. We're still waiting for the final results on this study that I think will give us information going forward on the best way to select these high-risk population. When we look at how we currently enroll for lung cancer screening, we know that our numbers will continue to decrease. This in the yellow is never smokers who currently are not undergoing lung cancer screening under any criteria. And the only eligible participants are this very small red wedge here that have 30 pack years. So we know that we're missing those lighter smokers, those smokers who have quit beyond 15 years and still carry that high risk of lung cancer. We screen less than 40% of individuals who will develop lung cancer are eligible for low-dose CT screening. So we know that we're not capturing all the participants that need to be captured. When we use risk prediction modeling, we select around 60% because we incorporate sex and ethnicity and socioeconomic status, but we're still not reaching the ideal 80% of a population screened, which would be more effective. And we haven't even started to talk about non-smokers. These are all current or former smokers by both risk prediction modeling and age and pack years. So this is where we saw a place for breath biomarkers looking for screening selection. Could we incorporate a breath sampling or breath markers in combination with risk modeling to determine eligibility, and at that point also include never smokers? I want to change gears just for a quick second and show you another portion where another need where lung cancer screening requires another biomarker. Lung cancer screening is very sensitive with low-dose CT scanning, and we can pick up nodules of 2 millimeters or smaller. And the vast majority of those are going to be benign or not cause problems, but it's determining which ones are going to become lung cancer that becomes very important. And these are different types of nodules. So this is a CT scan showing a solid nodule, a part solid nodule where you can see it has a bit of a solid area, but this fuzzy area, and non-solid nodules, as well as cystic. And this is a nodule that's intimate related to a cyst in the lung, and we know that those are higher risk for lung cancer. And so the majority of screen detected nodules are very small. They're less than 1 centimeter, as you can see here from these screening trials. And the actual lung cancers that we diagnose in screened patients are very small. And this is why we see that stage shift. But the majority of lung cancers that we diagnose are less than 20 millimeters. The majority of them are on the periphery of the lung. As you can see out here, 62% of the cancers live way out here in the lung, which makes them difficult to biopsy. The thought is that the filter from the cigarettes has changed and increased or improved, and so the particulate matter travels out to the periphery of the lung. And so diagnosing these small nodules can be done one of two ways. The first is a CT-guided biopsy or a transthoracic biopsy, where you're using a CT scanner to put a needle through the wall of the chest and into the lesion. When the lesions are less than 20 millimeters, the yield is only 60 to 90% and is fraught with complications such as pneumothorax. You collapse this whole lung. You can have severe bleeding, and there has been fatal incidences with this. The other way to biopsy these lesions to determine if they are a lung cancer is transbronchial lung biopsy, which is endoscopic. So a bronchoscope is inserted through the mouth or nose down into the lung. And the problem is when they are small and they are peripheral, they're very hard to diagnose this way. They create really technical challenges that require very specialized equipment, and just flexible bronchoscopy is really futile in these cases. The diagnostic yield is a little lower than CT guided, and there still are complications, although the complication rate is much less. So as you can see, we now have a situation where we have many nodules. We need to determine their malignancy risk going forward because they're difficult to biopsy, and we want to decrease downstream investigations, which can have increased risk. So at this point, a biomarker such as breath added to the baseline CT scan to us seems like a very feasible introduction into the clinical pathway. Just to reiterate how difficult it is to follow these nodules, this is a paper that we recently published on lung cancer screening guidelines in the Canadian Journal of Respiratory and Critical Care and Sleep Medicine. And this just shows that around the world, all the nodule guidelines and the discrepancies for the same size of nodule. So in the green means that, it's a 5 mm nodule. The patient should just go on to their next scheduled 12-month CT screen. The yellow means that we should increase the screen, so move up and do an early recall. And the red means go to a clinical pathway where you're either pursuing biopsy or you're using PET scanning. And you can see the discrepancy between the guidelines for solid nodules. That discrepancy increases even more for part solid nodules, and it becomes even more noticeable in the non-solid. So you can see that following these nodules creates a real problem. I think there are really two main unmet clinical needs in lung cancer screening that we could use a biomarker to help us refine. One is, as I introduced, who do we select? Who are truly those high-risk population that we need to screen, who will benefit more from the screening? And two, how do we characterize these indeterminate nodules that we find during our baseline scanning? How do we know which ones we should pursue with biopsy or recurrent follow-up, or have a more lax follow-up with a 12-month or a 24-month follow-up? There are currently explored many biomarker candidates in lung cancer screening. We're quite early on in it, but as previously talked about, the liquid biopsy is gaining most popularity. It's easy to do a blood sample. Currently, microRNA and circulating tumor DNA, as well as DNA methylation, are being looked at. And the origin, I guess it depends what you think, where you think the biomarker is coming from. I think in lung cancer screening, because we're dealing with these 10 mm or very small tumors, I'm not entirely convinced that it is the actual tumor that we're going to pick up a biomarker from or see these sources from the actual tumor, but I think it's the microenvironment and the entire host that are changing, and those are the signals that we're going to see, which is why I think exhaled breath could be very helpful in this area. It's also non-invasive, so when you ask a patient if they'd rather give a breath sample or a blood sample, they're going to say a breath sample every time. The criteria for a clinical biomarker in this pathway, we already know that low-dose CT scanning causes a stage shift, but what we need to do is focus on reducing the false positive rate and add value changer management to the benefit of the patient, which overall gives us cost effectiveness and in the end equals cancer control. So that brings me to a study that we have just recently completed. We did it in conjunction with Owlstone. We looked at the volatile organic compounds for nodule classification in a screened population. This was a pilot or feasibility study. It was a prospective study looking at high-risk lung cancer screening patients, and we divided them into 3 groups. So our first group were screen-detected cancers that were biopsy confirmed, and we had 23 participants that had biopsy confirmed cancers. We had 26 patients that had indeterminate nodules. The way we based our nodule risk stratification is currently on the PanCan nodule risk score, and I'm going to show you how we do that in detail on the next slide. And then we had participants who had been followed in a screening trial for greater than 5 years with nodules which have been stable for greater than 5 years. In clinical pathways, if a solid nodule has shown stability for greater than 2 years, it is deemed a benign etiology and we don't continue to follow it. Part solid or non-solid nodules, we follow up for 5 years. So all of these participants had greater than 5-year stability. Another category came up, and we originally didn't classify them this way, but over time, patients who were deemed to have a cancer and then underwent surgical resection, were found to have another diagnosis outside of cancer, and I'll share those. Those were 9 participants that I'll show you their diagnoses. I just wanted to review the PanCan lung nodule risk calculator so you could see the type of risk that we are stratifying these nodules by. So this was published in the New England in 2013. It is now available as an Apple app, so you can have it on your phone and plug in this data. And is part of the BTS nodule pathway and guidelines. So the nodule calculator includes age, because we know as patients age, they have a higher risk of having a lung cancer. Sex is included, family history of lung cancer, whether or not the patient has emphysema, the nodule size in millimeters. Obviously, larger nodules have a higher malignancy potential, and the type of nodule. And again, solid or semi-solid have higher malignancy potential than the ground glass nodules, and an upper lobe location is known to have a higher malignancy predilection. Speculation is an important, and that's where on the CT scan, if the nodule looks like it's got these spicules or these little fingers coming out into the lungs, that's more concerning for malignancy versus a nice round border. The nodule count is important because when we see very many tiny little nodules or micronodules, those are much less likely to be malignant. So once you punch in all of these, you come up with a risk score. We then put that risk score into categories. So if your nodule risk score was less than 1.5%, you would go on to a biannual or 24-month scan. If your risk score was low, between 1.5 and 6%, you would go on to an annual CT scan. But if your risk score of your nodule or nodules were between 6 and 30%, these are those moderate malignancy risk, or what we would deem an indeterminate risk. So we don't know if they're necessarily a malignancy, but they need an early recall, so an early low-dose CT scan in 3 months, or moving on to a PET scan if you're more suspicious. So all of the participants were former smokers. As Dr. Risby had mentioned earlier, we didn't want current smokers. These were defined as having quit for 1 year. And at the time of breath sample, prior to breath sample, they all had a CO breath test to ensure that there was no, they hadn't had a cigarette. We were using urine continent, but we found that a lot of the participants were still on nicotine replacement, so that became positive. And we actually ended up doing dual urine continent and CO monitoring. They were all aged 55 and 80 years and had a breath biopsy by the Receiva breath sampler. We then shipped the breath samples to the Owlstone lab for analysis. And the lung cancer patients actually had a post-surgery sample 3 months post-surgical resection so that we could use those patients as their own controls. However, unfortunately, some of those samples were not viable, and then there was an issue with the machine in the lab. So we were unable to get this information, but I will share with you the information that we have. So of the participants enrolled, you can see we had 23 confirmed with cancer, 26 were these indeterminate nodule risk, and we had 21 controls. 9 were originally in the cancer, but after biopsy or surgery, they were reclassified as an other diagnosis if they weren't confirmed cancer, but they had a confirmed diagnosis. With the sex, you can see slightly more females than males, but all were very heavy smokers who had quit 14, 15, 17 years ago. Their smoking duration was quite high. They had smoked for 37 to 39 years with a pack years equivocal of 45, 41, plus or minus 19 years. So all very heavy smokers who had quit at least 15 years prior. Their baseline low-dose CT scan findings demonstrated in the cancer group, more had emphysema, but emphysema was prevalent through all groups. The nodule risk score, as predicted, was higher in the cancer group than the indeterminate nodule or the controls. And the type of nodules we saw were predominantly solid, and this is well known or common in screening groups. The majority of cancers that we diagnosed were adenocarcinomas. There were a few adenosquames and squamous cell, as well as there was one myofibroblastic tumor, which is actually quite rare, and we were surprised to find that, but we did. As per screening cohort, the majority of our cancers were early resectable stage. We did have some later stage. A 3B is a non-resectable stage, so this person would have had chemo and radiation prior to resection and then underwent resection. This is the histology of the 9 patients that had biopsies or resections that actually turned out not to be cancer. And you can see we've got things like sarcoidosis, scar tissue, which was interesting because these were actually PET avid and did demonstrate growth. And we had one with metastatic pancreatic cancer. Some of it were infection, atypical mycobacteria, and fibrosis. So the molecular features that we saw, there were actually over 67 molecular features that were tested, and 22 differed significantly between cases and controls using a non-parametric 2-sample test. Of those, there were 8 molecular features that showed significant difference between the control group and the cancer group after multivariate analysis, which was interesting. We did find that there were 3 aldehyde groups that had abundance in the cancer patients, and were able to separate out the controls, which you see are in blue, and the black, which were in cancer. And this is in keeping with previous studies for lung cancer. It may relate to the reactive oxygen species and lipid peroxidation in the microenvironment that we just heard about. We also saw 5 groups of hydrocarbons, or 5 molecular features that were hydrocarbons that showed out separation between the cases and controls. Although this is less well established in terms of what it represents in terms of lipid peroxidation. This is the receiver operator curve based on the 3 top features. You can see the standard deviation is in this shaded area, and the sensitivity is 75% with a specificity of 80%, which is quite high, but we do recognize this is limited by quite a small sample size, and this could be over or under estimation due to our sample size. We have looked at power calculations, and in future studies, need only approximately 40 to 50 patients in each group going forward. The interesting thing is you'll notice that in the cancer group, we did notice they had more COPD and more severe COPD. So we wanted to make sure we just weren't picking up COPD versus more healthy lung tissue or trivial emphysema. So we looked at this specifically using a one-way ANOVA test to look for significant differences between COPD severity and the molecular factor abundance. And it didn't actually change any of our significant molecular factors, but we did note that there were 2 molecular factors that did separate out mild, moderate, and severe COPD, which I think is really important because we wanted to ensure that we weren't just picking up this COPD signal. As time went on, we were able to reclassify patients as these indeterminate nodules follow over time. And that's basically what we're left with when you normally have an indeterminate nodule, you repeat CT scans, and either you go on to biopsy or you follow it for 2 years and it becomes a control. So you can see that some of these indeterminate nodules now are in the control group as they've completed 2 years of follow-up. And the trends visually remained largely consistent. There were a few changes. 2 of the original top 8 suffered a large reduction in statistical significance, and 3 new molecular factors increased in statistical significance, passing that threshold. So it did alter things somewhat. But I think, you know, that in this relatively small cohort of patients, 80 patients, we found several promising candidate breath biomarkers that potentially could detect lung cancer were identified. And I think what really this shows is it demonstrates the merit and feasibility of incorporating breath biomarkers into lung cancer screening strategies at several points. This study shows that it is very useful for, or has the potential to be very useful for future studies looking at indeterminate nodules, but larger trials obviously need to be completed. We are awaiting the LUCID trial results and for validation of our molecular features in this, so that'll be helpful. And going forward, British Columbia is the first province in Canada to now have a provincially funded lung cancer screening program. So starting in 2021, all participants that have a smoking and pack year criteria or PLCO M2012 criteria will be included for lung cancer screening. And we have been able to incorporate a research arm into this. So going forward, we will have access to large amounts of screened participants where we can incorporate breath at certain points. And I think the 2 points are just looking at 1, how do we identify those high-risk population? And 2, how do we help manage? Can we use this breath biomarker to help manage indeterminate nodules? I think breath biomarkers, especially with the Reciva, were easy to introduce into the point of care. We had the Reciva in the clinic, and it was easily accessible and non-invasive, which makes it very feasible. I do want to acknowledge my team at BC Cancer and my mentor, Stephen Lamb, as well as the rest of our team that made this possible. The radiologists who read all the baseline CT scans, and our pathologist, John English, who also did all the pathology. And of course, the Owlstone team, who we partnered with, especially Dr. Mark Vandershay, Max Ellsworth, Chris Hodgkins, and Owen Birch. And so I'll leave off there with a picture of this summer. This is my daughter kayaking on the Sunshine Coast. So once we are able to safely travel, please come out and visit our breath lab and come see us. It's a great place to be.
Fantastic. Thanks so much, Renelle. I know for one that I'm itching to try and leave my house more than once a day. That was wonderful. Really appreciate the talk. So lots of questions coming through now. I was wondering if I could just kick us off. So I think one of the points that you made was really interesting. So when you think about what VOCs are being produced and what that then represents, so it not necessarily being from the tumor itself, but thinking about changes to the microenvironment or changes to the host itself. Do you have any kind of thoughts, or could you elaborate a little bit more on that, the types of mechanisms or things that you think may be going on there?
Yeah, I think, our group it falls under integrative oncology. So we work with a huge group of scientists. And, there's a lot of focus in cancer now on the microbiome and how that is changing. And does that, the chicken or the egg, does the microbiome in the patient make them more susceptible to a cancer, or does the cancer change the microbiome? And so I think, it really is the microenvironment, because I don't think these, 5 or 10 millimeter tumors are going to give us a signal. I think it's the environment around them.
Yeah, no, that makes a lot of sense. So one of the questions coming through, have you identified the VOCs themselves? So for those molecular features, is there ID for them?
Yes, we have with the NIST as a tentative identification. We obviously have to validate that, but we have tentative IDs of those molecular features. Yes, and the reason I didn't share them with you is just we are publishing this, so we'd like to get it published before we share everything, all our secrets.
There's another question here. I think it may relate back to the first one. So do you expect the type of lung cancer to have significant impact on the breath VOC profile?
The type of lung cancer? I guess it could, but the one thing that we know with large screening trials, and there's enough data out there that we know, the majority of cancers in lung cancer screening trials, and the majority of cancer these days is adenocarcinoma. It really has taken over from small cell, whether that's the way cigarettes are filtered, whether it's other mechanisms, but the majority is adenocarcinoma. We do pick up small cell. Small cell is a rapidly progressive tumor that isn't really amenable to screening. So we have just completed 2,000 low-dose CT screens in our screening project at the BC Lung Screening Trial. I think we diagnosed 2 small cells. The rest were adenocarcinoma, a few squames, but the majority really is adenocarcinoma.
Fantastic. So this question's more related to the logistics. So for studies like the BC Cancer Pilot Study, do these trials have to be registered under a government entity like clinicaltrials.gov, or are they done stroke approved completely internally?
Yeah, so these trials are all have to go through the ethics at the University of British Columbia, so it's done internally. Obviously, with a larger international lung screening trial, we partner with people around the world, and they're registering their trials with their facilities as well.
Great. Another question, there was an abstract a couple of years ago showing increasing predictive ability with scoring of structural microenvironment on CT. Are you going to see if structural abnormalities in CT correlate to the exhaled breath profile? I don't know if some of the things in the scoring, in the nodule scoring,
yeah,
algorithm are already there.
I think what's really important is you bring up, it's a great question, because we know that radiomics and deep learning at looking at these nodules is also very important. And I think that, pairing breath with radiomics would be a very important way to go, and an easy way to go, because radiomics is certainly uh, actively being investigated. We have a group at our center that is looking closely at all of our nodules with radiomics, so we're easily able to pair with them as well. But I think combining breath biomarkers with radiomics would be important, and seeing the different signals corresponding, it might give us a little more insight into the biology of cancer as well.
So one question relates back to COVID-19. So whether or not you think this would have an impact in the longer term on progression to cancer for some lung nodules?
Yeah, that's a really good question. So COVID-19, we're actually in BC, the first wave in March, we did quite well. Our numbers were managed quite well. And despite that, everything shut down and was delayed. This time around, our numbers are higher. We're under a partial shutdown right now. But what we have tried to do is keep lung cancer, even though some elective surgeries were canceled, certainly lung cancer surgeries, bronchoscopy for lung cancer diagnosis and staging was not delayed at all. So although COVID-19 has raised a lot of challenges, and how do we safely continue to do this in this era, we have tried really hard not to let that affect cancer patients. And I think the imaging of COVID-19 is entirely different and quite specific than a lung cancer nodule. And when you're doing screening, when you see these patchy ground glass infiltrates, that's more in keeping with COVID-19, which would raise our alarm, versus a solid nodule. So, we would have a scan, we'd look at it. If there was no ground glass infiltrates, we would go ahead and continue to biopsy and treat these patients. What COVID-19 has done is wreaked havoc on all my other studies where I can't enroll patients, and has shut down shut down our research institute to patients. And so that has been our biggest challenge.
Yeah, no, I hear you. We've seen similar issues here, and I think a lot of the partners that we work with, that's been a big challenge through the COVID shutdown. So one more question I think we have time for. So do you believe the specific group of young women without smoking history developing lung cancer will have a specific breath signal, and would that be different?
I do. I think, it may relate to, so at BC Cancer, we know that 40% of patients who present or are diagnosed with lung cancer are never smokers, and 80% of them are females, and 75% are Asian females. And so I wonder if it's the way they metabolize. So if they're exposed to air pollution, or they're exposed to other factors, it's how they metabolize that. So I do think they would have a different sample, but we haven't started. That's one of the trials that we can't get off the ground because of COVID, but we will be looking at that too.
Excellent. Well, I think that's all we've got time for. So just wanted to thank you again for a really fantastic talk. Really appreciate you joining us so early today.
Well, it's actually not very early now, but yeah, thank you very much for inviting me.
Excellent. Thanks a lot, Renelle.